Good morning friends, welcome back to my YouTube channel Medical Classes by Dr. Srinidhi Kumar Acharya. Please don't forget to subscribe to my channel and also please give your valuable comments. You can also visit the playlist. In the playlist I have provided almost all the topics in a very systematic order. I hope this will be very convenient for the continuous study. My dear friends, we have been discussing about precocious puberty. Already we have covered 3 classes. And one class we have taken the general introduction, and the second class we have discussed a case related to central precocious puberty, and another class we have studied about precocious puberty, peripheral precocious puberty. So today we shall have continuation of the same, and today we will discuss one more important case actually related to precocious puberty, peripheral precocious puberty. Now, just to recap, in central precocious puberty, we know that all the puberty changes will occur in order, and they're all CNS dependent. CNS dependent in the sense either it is related to hypothalamus or either it is related to pituitary gland secretions or either it is related to gonadotrophin releasing hormone. Their excess secretion or their excess activity may lead to this particular problem of central precocious puberty. How to identify? We know that yes, central precocious puberty, although pubertal changes are occurring faster than the given time, but they always follows the order. They always come in the order of telarche, adinarche, menarche, and as well as growth spurt. That means in case of male, whereas in case of female, we know that telarche will be there, adinarche will be there, growth spurt will be there, and then there will be menarche. So this order will be always followed. But in case of peripheral precocious puberty, PPP, the puberty changes are not dependent on gonadotrophin releasing hormone, pituitary gland or hypothalamus. Rather, they are either related to the adrenal gland or they are related to the mammary glands, they are related to the ovary, etc. Second thing is they will not occur in a sequence. Okay, they will not follow the sequence of telarche, adinarche, growth spurt, and as well as menarche. Menarche may come earlier than the telarche, or sometimes adinarche may come before telarche, or sometimes nothing is coming but only menarche will be there. So they are not following any sequence. So this is how we have to differentiate PPP. Now, talking about peripheral precocious puberty, today's class we are focusing upon one important fact, that the most common cause of peripheral precocious puberty in female, that is hypothyroidism. Very important, and nowadays hypothyroidism becoming more and more common, and this hypothyroidism is a major cause of attaining precocious peripheral puberty. Now, in this case, so when hypothyroidism is the cause for the peripheral precocious puberty, the changes may not be due to the overproduction of the androgens. Now this is quite different, or from the adrenals, or there is not even any tumors present in the adrenals, or it is not even because of the effect of the drugs or some of the chemicals which are present in our diet, like biochemicals, etc. Then what is the cause for this hypothyroidism causing peripheral precocious puberty? The most common cause of peripheral precocious puberty is always hypothyroidism. Okay, so in this case, now peripheral precocious puberty due to hypothyroidism, in this case the changes are either again isosexual, gender appropriate, or it may be heterosexual. This is also possible. Now, coming to the real fact of untreated hypothyroidism, which is the most common cause of peripheral precocious puberty. The problem is when there is child is having hypothyroidism, female child is having hypothyroidism, we have got decreased levels of T3 and T4. Probably the TSH which is produced from the pituitary gland is not able to stimulate the pituitary gland thyroglobulins, thyroid gland thyroglobulins. Okay, the follicles of the thyroid gland is not able to get stimulated by the TSH. That means what the main function of the TSH is come to the thyroid gland and get bind to the receptors which is present in the thyroglobulins and initiate the function of production of T3 and T4. This is a function of a TSH. When this TSH is not utilized properly by the thyroid gland due to various causes, the level of the TSH percentage, the level of the TSH, thyroid stimulating hormone, will going to rise in the blood because it is not utilized. So its level will going to rise in the blood. Now here comes the problem. Structurally, the structure of the TSH hormone and structure of the follicular cell stimulating hormone are one and same. Structurally, they are inseparable or unrecognizable. Their structure is one and same. Now what happens is the TSH level is now raised in the blood in case of hypothyroidism because it is not utilized. The same TSH now travel in the blood and it reaches the ovaries. So when it comes to the ovaries, now ovaries are unable to differentiate it from the follicular cell stimulating hormone because their structure mimics one and same. Their structure is mimicking. Okay, so what happens is this TSH will be accepted by the ovary. Okay, TSH, thyroid stimulating hormones, will be accepted by the ovaries, get bind to the ovarian receptors because ovary think that this is nothing but FSH only. And now because of this mistake, what happens is now the ovarian proliferation takes place. See, quite interesting. FSH has to do this work, but FSH and TSH structurally mimics one and same. Therefore, ovaries get confused, and this TSH now bind to the ovarian receptors, and changes starts in the ovary. Ovarian proliferation takes place, and there is production of estrogen and progesterone. Okay, so this is how the peripheral precocious puberty is found because of hypothyroidism. Okay, hypothyroidism is the cause. Now here, suppose child may not be till attained the telarche. Child is not in the phase of adenarche also. But if child is having hypothyroidism, by skipping all these schedules, directly there may be production of the estrogen and progesterone from the ovary because of this structural mimics. Okay, so but in the central always order is followed, but here the order is not followed. There is no order. Directly the estrogen and progesterone produces, and once the estrogen and progesterone produces, the menstrual changes takes place and child will develop menstruation, and we will call it as precocious puberty. In that also it is because of the peripheral precocious puberty. In that also it is because of a hypothyroidism. So if we analyze in this case, normal sequence is not maintained, and so therefore we have to consider this as peripheral precocious puberty. Now, how to differentiate the other causes of precocious puberty from the hypothyroidism as a cause of precocious puberty? Now, hypothyroidism is one of the major causes of precocious puberty, especially peripheral precocious puberty. But there are so many other causes also which may cause peripheral precocious puberty. In hypothyroidism, the child will have the short stature also. We have to now look into the other symptoms of hypothyroidism also. Child is having peripheral precocious puberty. Along with that, if the child is having short stature and if the bone age is delayed, then definitely yes. If it is started earlier, the mental changes are also evident. Now see, hypothyroidism also causes the mental retardation because T3, T4 is very important even for the neurons. Okay, so if the neurons are not properly formed, yes, definitely child will have mental retardation. Therefore, always will say screen the baby immediately after birth for hypothyroidism, because hypothyroidism is one of the treatable cause of mental retardation. From the immediately after birth, on the day 4, day 5 or day 10, if you are able to identify that yes, child is having congenital hypothyroidism, you start with the thyroxine and other drugs, and so that you can prevent the mental retardation. Hypothyroidism which is occurring after the age of 15 or 16 does not matter, because by that time brain development is okay. So child will not have any much mental retardation. Maybe dullness may be there, but mental retardation will not be there. But in the newborn child, definitely we will have mental retardation, because in the first 2 years of the life of the baby, the brain growth is very rapid and maximum. So therefore, hypothyroidism in the newborn, it is called as a treatable cause of mental retardation. Anyway, in this case, If the girl is having peripheral precocious puberty, along with there is some of the symptoms and signs and symptoms of hypothyroidism like short stature, delayed bone age, and some of the mental dullness or lazy and constipation, etc. Yes, definitely it is a case of hypothyroidism. In all the other cases, bone age normal with the precocious puberty. If the precocious puberty is because of other causes, okay, then the bone age will be normal, but it is in hypothyroidism, bone age will be delayed. We must look for some of the neurocutaneous markers also, because they may be also sometimes the cause of this precocious puberty. Now, we have to look for some of the neurocutaneous markers. Some of the syndromes with the neurocutaneous symptoms are also associated with the peripheral puberty. Okay, so what are those disorders? We have got to McCune-Albright syndrome. This is also one of the cause for the peripheral precocious puberty. But in case of McCune-Albright syndrome, there will be a triad of fibrous dysplasia, abnormal pigmentation, along with the precocious puberty, peripheral precocious puberty. And neurocutaneous symptoms or markers, they are important. For example, neurofibromatosis. Another cause is neurofibromatosis, and there is some genetic influence. We know that it's autosomal dominant disease, some genetic influence, and also the age of the mother's menarche is also very important. Mother's age of menarche is also very important in this case. So, McCune-Albright syndrome, neurofibromatosis may be also a potential differential diagnosis for peripheral precocious puberty due to hypothyroidism. Now coming to the investigations part, if you want to see, yes, for the thyroid, yes, you have to go for the thyroid profile test, and in this case the bone age of the child will be delayed through the chronological, although the chronological age is lesser than that. So this is done by the Glosspile Atlas method. Reference images are used to compare, like X-ray of the wrist, knees, etc. And this is most commonly used method. Lastly, it was updated in 1959. Then another one is Tanner's White House method is used for the wrist of the left hand is used as a reference point called as bone reference points, BRP. Okay, these are all the methods in case of hypothyroidism to estimate the bone age, because in hypothyroidism along with the PPP always bone age will be delayed. So that bone age, how we have to assess, these two methods we can follow. So like this we will have different investigations. Rest of the things regarding this we will see in the next class. Thank you very much.